This is, after all, the core feature of acute anorexia nervosa. And we saw individuals who, on average, presented at very low BMIs, coming in at somewhere around 15 or 16 as a mean BMI to start, who really did have a lot of progress that we were hoping that they would make. And even this modest amount of progress is really quite notable.
That's Evelyn Attia from Columbia University and Weill Cornell, who will talk about her research on anorexia nervosa. Her work appears in the June 2019 issue of the American Journal of Psychiatry. I'm Michael Roy, Executive Editor of the American Journal of Psychiatry, and this is AJP Audio. Dr. Evelyn Attia is the lead author of an article in our June issue entitled Olanzapine versus Placebo in Adult Outpatients with Anorexia Nervosa, a randomized clinical trial. Dr. Attia is a professor of psychiatry at Columbia University Medical Center and at Weill Cornell Medical College. She is the director of the Eating Disorders Research Program at the New York State Psychiatric Institute, and she is also director of the Columbia Center for Eating Disorders at Columbia University. Her research has focused on the psychobiology and treatment of anorexia nervosa. She was a member of the DSM-5 work group on eating disorders. She is a member of the Eating Disorders Research Society, and she has been elected fellow of the Academy for Eating Disorders. Hi, Dr. Attia, and welcome to the podcast.
Hi, it's wonderful to be here.
Now, your study compared the benefits of olanzapine, an antipsychotic medication, with placebo in adult outpatients with anorexia nervosa. First, could you talk about why you and your co-authors decided to study this issue?
Sure. Anorexia nervosa is not a new illness. It has been around for centuries, actually, and it remains quite a challenge to treat, especially among adults. This is an illness where we now have some evidence-based approaches that are very helpful in our youngest patients who, for the most part, have been ill for a shorter period of time. But among adults who are more chronically affected especially, the evidence-base is really quite sparse. These are individuals who have a whole host of psychological symptoms, mood symptoms, anxiety symptoms, obsessional ideas, and a set of behaviors that really do get them into trouble. For a long time, we have hoped that the symptom overlap between what we see in anorexia nervosa and what we see in some other psychiatric conditions might mean that there are medications out there that could be helpful. Yet most clinical trials have really come up empty without there being a single medication that has proven helpful when compared with placebo for this very serious psychiatric illness. And this is an illness with a high morbidity rate and a mortality rate as high as what we see in any psychiatric condition. We decided that olanzapine was worth studying after having noted a number of open series in the literature and then small pilot studies. Some of the same co-authors, conducted a small pilot study ourselves, trying to see whether there was somewhere we could get with an atypical antipsychotic medication that could be helpful to these patients. And olanzapine offered a number of possible benefits. This was a medicine where we wondered whether the high anxiety and the near delusional beliefs that are seen in some patients with anorexia nervosa might improve. This is also a medication where weight change, weight gain, has been described in other clinical populations, and we wondered whether we could capitalize on that and have our patients benefit from the effects of this medication. Of note, lots of other medications that are associated with weight gain in various clinical populations had not previously been associated with weight gain in studies of anorexia nervosa, so we were far from sure whether this medicine would affect these patients in a helpful way. And we were delighted that we really had the first medication study that offered a measurable, statistically significant weight benefit to these individuals.
Well, let me give our listeners a brief description of your study. The participants were randomly assigned to receive olanzapine or placebo and were seen weekly for 16 weeks at 5 different locations in North America. Now, the study focused on the rate of change in body weight as well as the rate of change in psychological symptoms. So could you tell us why your team wanted to look at these 2 primary outcome measures?
We were interested in looking at change in weight, actually change in body mass index, in BMI, in this study, because significantly low body weight is the core sign, presenting sign, in anorexia nervosa, together with a number of associated psychological features that really gets our patients into the kind of medical and psychiatric trouble that leads to the great seriousness associated with this illness. So we knew that if this medicine was going to be of assistance to our patients, we wanted to include change in BMI as a primary outcome that we'd measure. We came upon the obsessionality score and the look at the Yale-Brown obsessive-compulsive scale as a specific way to measure obsessionality somewhat circumstantially. There was another study that had preceded ours, a pilot study conducted by Haney Besada out of Ottawa, that looked at olanzapine among individuals participating in a day treatment program, individuals with anorexia nervosa. And that group of authors found that obsessionality improved in addition to the improvements seen in weight. We specifically wanted to replicate and extend the findings that had been published by Besada et al. In fact, there was a little bit of grantsmanship as we submitted our proposal to the NIH, where reviewers asked that we target some of our outcomes to others that had been measured previously, and so we selected this particular measure of obsessive and compulsive symptoms. As we initially proposed this study for peer review and along the way as we initiated the trial, we realized that we would be up against the challenge of recruiting patients who needed very much to change weight into a study where they would be asked to take a study medication that was associated with significant weight change in other clinical populations. And many of our colleagues said this study can never be done, that we would be up against patient reluctance, patient resistance, and that we might have real trouble getting these patients into the trial. We were delighted that with some good efforts at explaining why this study was an important one, really sharing with our patients the information we had from pilot studies about the modest rates of weight change that had been seen by other of our colleagues who had worked in this space before. And with the help of some medication adherence strategies, really helping patients think about the pros and cons of giving this medication a try, we actually had great success in bringing patients in and keeping them in the trial. We did have dropouts, certainly, but we had some 70% of our patients participating in at least 8 weeks of a 16-week trial, really giving us an opportunity to collect sizable amounts of information on patients, their weight trajectories, their ability to tolerate this medication. And we were pleased with the success of the recruitment and retention that was possible in this very large trial.
Okay, so let's get to the results. What did you and your co-authors find?
So we found a statistically significant change in BMI, change in weight, associated with those who were receiving the active medication, receiving the olanzapine. And that change in weight was different from what we saw among those assigned to receive the placebo. This was a modest change, something on the order of 1 BMI point per month of an increase among those assigned to olanzapine, and something much, much smaller, closer to 1/10 of a BMI point per month among those who received placebo. And what this translates into for the average height woman, someone who might be about 5'5", is something like an additional pound per month of weight gain throughout the duration of the study. So we did have a little bit of weight progress among those who were receiving placebo, and we were, after all, seeing our patients regularly. There was a psychiatrist meeting with participants every week for the duration of the study, even among those receiving placebo. And so some of those folks were gaining at a rate of maybe about a half pound per month. But for those receiving olanzapine, the rate was something like 1.5 pounds per month, a more significant, more consistent rate of change. I can't emphasize enough the importance of seeing any weight progress in a study of outpatients with anorexia nervosa. There have been many, many medication studies before ours. There have been medication studies in which patients were receiving a lot more treatment than what we were offering our participants. And we were really just offering brief, relatively supportive, medication adherence-focused conversations with a psychiatrist together with the study medication, either olanzapine or placebo. And our folks with that treatment alone were making change in their weight along the period that we were examining them. And this is, after all, the core feature of acute anorexia nervosa. And we saw individuals who, on average, presented at very low BMIs, coming in at somewhere around 15 or 16 as a mean BMI to start, who really did have a lot of progress that we were hoping that they would make. And even this modest amount of progress is really quite notable.
Yeah, let me underscore the emphasis of this finding, because your observation that olanzapine was associated with a significantly greater change in BMI, it's clearly depicted in Figure 2 in your article. The difference is clearly notable. However, there was no such evidence that the drug had a significant effect on key psychological features of anorexia. Are these kinds of symptoms difficult to treat in patients with this disease?
To be frank, we were disappointed that we didn't find additional psychological improvements associated specifically with olanzapine compared with placebo. Of note, the entire study group did improve in terms of a range of psychological symptoms during the study duration, but we weren't able to see additional benefits specifically in the medication-assigned group. We were somewhat surprised about this finding. We had hoped that there might be an improvement in anxiety or an improvement like Basada and co-authors had found previously, improvement in the obsessionality. And we didn't see this. We are now taking a closer look at some exploratory hypotheses, some secondary analyses, wondering whether we may have, among subgroups of responders, something to say about the ways that their psychological symptoms interacted with their medication response. But in terms of the entire group, we did not find group differences in psychological change. There's certainly more to learn. Another important finding we had in the trial had to do with our close monitoring of medical features as we followed our participants, specifically for olanzapine, which is known to affect a number of metabolic factors in other clinical populations. Olanzapine is known to affect glucose metabolism, triglyceride function. We were concerned that our patients might have side effects that would make the use of this medication complicated. And we found consistently that the patients were able to tolerate these medications. We didn't have anybody develop worrisome hemoglobin A1C or glucose levels. We didn't need anybody to exit the study due to any significant changes in triglyceride, cholesterol, the kinds of metabolic changes that are seen in other populations. There's no question that this brings up the potential for other research initiatives in this patient population. Why aren't we seeing the kinds of metabolic changes that all other clinical population seem to have when they are taking olanzapine. Some of this may relate to the very different category of weight that our patients present with, but some of this may have to do with other physiologic realities that are specific to anorexia nervosa, and it would be very interesting to additionally study this group and see if we can learn more.
What other aspects of your study are relevant for researchers, clinicians, and other mental health professionals?
I think there are a number of features of this study that are very, very useful to clinicians. It's easy to take a look at modest progress associated with a medication such as olanzapine and say, my goodness, that's not curing, that's not changing the illness as dramatically or as robustly as a clinician might hope for their patient. With that said, this is a tool, and it's a tool that could be very useful for some of our patients who present the challenges of a very difficult illness, sometimes an illness that they have struggled with for a very long period of time. And to have a medication that is associated with some notable change to weight, and potentially over a period of time, more comprehensive change, is really something that we want clinicians to have as a take-home message. The other point about this sample is that these were outpatient adults. For the most part, because of the processes that we, of course, require our research participants to engage in, letting us know that they are fully informed about the study and understand what all their alternatives are to treatment. For the most part, we wound up with a group of participants who didn't want the higher level of care treatments or had tried other approaches and they weren't successful trying those. These weren't, first trip around the rodeo types of participants. These were folks who had been ill for some time and wanted to engage in an outpatient intervention. To have something that we can offer such individuals, that we can offer, maybe in addition to other outpatient strategies, that we can offer outpatient adults with potentially chronic, certainly serious psychiatric illness such as we commonly see in the eating disorders world with these patients with anorexia nervosa, is really potentially helpful, even if it's to a subgroup of the individuals with this condition. Another interesting and potentially important observation in the course of the trial concerned our monitoring of a whole list of somatic features. We were interested, of course, in whether our patients receiving olanzapine might have side effects that were of concern to them along the way, and whether these differed across our two comparison groups. And we found that our patients taking olanzapine tolerated the medication very well, didn't have complaints of some of the usual somatic symptoms that were very different across groups. But actually, those taking olanzapine had 4 areas where they reported improved comfort, improvements in the area of trouble concentrating, improvements in a rating of difficulty sitting still, in terms of trouble falling asleep, in terms of trouble staying asleep. Participants receiving olanzapine had less trouble in these areas, statistically significant improvements in these areas compared with the group receiving placebo. And we took note of that because while we didn't find the psychological improvements we were looking for, we were interested that there were these measures of improved comfort among those who were taking the active medication.
Dr. Evelyn Attia, lead author of an article in our June issue on treatment of patients with anorexia nervosa. Thank you so much for speaking with us.
Thank you so much.
This concludes this episode of AJP Audio. You can rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. Please also visit our website, ajp.psychiatryonline.org, to check out trending articles, find CME courses, and watch videos highlighting some of our other articles. be sure to check out 2 other podcasts from APA Publishing. Psychiatry Unbound, our newest podcast, is APA Publishing's Books podcast. It's hosted by Dr. Laura Roberts, editor-in-chief of APA Books. You can hear the voices behind the most prominent scholarship in the field of psychiatry today. Also, check out From Pages to Practice, which reviews the latest research published in the journal Psychiatric Services. It's hosted by Dr. Lisa Dixon, editor-in-chief of the journal, along with Dr. Josh Barrison. You can find these podcasts on Apple Podcasts, Spotify, Google Play, or on the podcast page of the American Psychiatric Association's website. Next month on the podcast, we'll talk with Mark Halko from Harvard Medical School about his research on treating underlying symptoms of schizophrenia. We hope you'll join us too. Thank you for listening.